Hey everyone, good evening. Hope you're doing well. We have a very exciting live today. Haven't done one all week, so I feel like I really need an Instagram live. We are going to have Reena on today. She's one of my really good friends. She's a specialist endodontist, and we're going to be talking all about perio-endo. So I'm going to get her joined on. How's everyone feeling about going back to work now that we finally can? I think everyone's panicking and trying to get all their prep ready, and it's spent the whole day like sorting out my timetable, and it's but it's good news overall. I'm really pleased. So Reena is joining. Hey.
Hi, how are you?
Good. How are you?
I'm good, thank you. Yeah.
Really nice to see you again.
Yeah, nice to see you again.
We're seeing more people over Instagram now than in real life because of the COVID.
Yeah, I know. Tell me about it. Maybe not since June the 8th, though.
Yeah, true. How was your day? I guess we're all preparing now to open, so.
Yeah, I mean, this week's been super busy because we've been getting the practice ready to open anyway. Just by doing sort of the basic things like getting the Perspex shields up and all the staff training. And I guess today was just trying to source these like masks and fit testing and all that sort of thing. So it's been a bit manic, to be honest. What about you?
I think 1 week notice is probably not enough. I think we would have all preferred a lot more, but hey, I think that overall the news is good, so I'm looking forward to going back. Thank you so much for agreeing to do this, because I always get asked about perio-endo, and I thought, the best person to get on board is you, endo queen. So
I think it's great to have a mix actually of like perio and endo together, because I think sometimes thoughts can be really aligned and sometimes they can be a bit different, so it's nice to have like both like concepts on at the same time.
Definitely. So for people who don't know you, just give us a little bit of background. And I mean, Reena and I met during VT actually. So we did our VT in the same practice in South London, where we both. You still live in South, right?
No, I've moved actually. So now I'm very near Ascot.
Okay. So where we both used to live a good few years ago now. So we met there, and then we kept in touch. So yeah, tell us a little bit more about yourself.
Yeah, so I'm an endodontic specialist, and my time's mainly spent in practice. So how you mentioned Croydon, so I've got practice in Croydon, and it's mainly a referral practice where I operate from, but it's also a general practice as well. And then I work over in Reading as well. So again, just an external referral practice. And then I teach part-time, so 1 day a week I teach on the Dent specialist program at Guy's Hospital, which I really enjoy, a bit of a mix of things, and it's mainly postgraduates but also some undergraduates that I teach as well. And then very much just courses and lectures and stuff like that, so a little bit of education for the rest of the time.
Nice. So a good mix of everything, I guess. I feel like my timetable is fairly similar. It keeps it really interesting, I think.
Yeah, definitely, because you're over at King's, aren't you?
Yeah, exactly. So, but yeah, every day is different. I think I'd get bored in practice the whole week, but yeah, I think it's nice to mix it up. So we'll get cracking. I've had loads of questions in. So we'll start off with, a lot of people are interested in the whole career pathway. And I get asked all the time as well, I want to specialise, how best can I go about doing it? Or even if I don't want to specialise, what would be the next steps? So for someone interested in taking endo a little bit further, what would be like the next few steps or the next best steps? And in terms of specialising, would you say that everyone has to do that? Is that the right thing? How did you decide that you wanted to actually take the specialist route and not, just be a general dental practitioner, but actually just focus on endo? How did you make the decision? Because it's quite a difficult one.
It's a really difficult decision because you're sort of thinking about the rest of your life, and I focus it on one topic. So I think the first thing when you're thinking about it is to really be sure that you want to sort of focus your time on one career. And the only way you know that is, I think, by doing endo to a slightly more advanced level. Whenever people ask me, I normally say to them, go on courses that give you a bit more of an advanced sort of idea on what endodontics is all about. So, getting involved in things like perforation repairs, retreatments, things like that. See if it's something that you enjoy first. And it's not for everyone, because, with endo, you're looking through a microscope for most of your day, and that's not for everyone. So you know, you don't have to specialise. You can just like endo and do that to a high standard. So a couple of the sort of more basic pathways are obviously courses, doing a diploma or an MSc. So that's usually a 2 or 3 year part-time thing that you can do. And you definitely get a lot more experience doing something like that. I mean, I'm sure it's similar for perio.
Exactly.
So I mean, for endo, it's very theory based, MScs and diplomas, and working on extracted teeth. So you practice all the techniques, but you normally practice them on extracted teeth rather than on patients themselves. Some diplomas and MScs, you get a little bit of patient contact, but not a huge amount. And I think that's where the specialist pathway, the MClin-Dent, will vary quite significantly from our diplomas and MScs, because you're doing a lot of diagnosis and treatment planning on complex cases with live patients, and also you get a lot of treatment sessions where you've got tutors that will sort of hold your hand through patients. And I think that's where there is quite a lot of difference with the training pathways for MScs and diplomas compared to specialist training. It depends how much you like it. If you just want to focus on endo full time, I would definitely recommend the specialist pathway, because I think the level of training that you get on those pathways is different. As you would expect, having done a 3 or 4 year full time program. So it is different, but I think it just depends on how much you want to focus your life on endo.
Fine. So it's however much you want to take it further, I guess. Your advice about taking it a step at a time is really good. I think you don't want to just jump into a specialist program. It's from both of our experiences, a huge commitment, both in terms of finance. My course, I don't know how much your course was. When I did my perio, I think it was about 14k a year, which is a lot of money. I mean, especially if you're not working. So, and a lot of people don't know the fees. So I think it's the finance, the time, and then, do you really want to just be doing that one thing the whole of your, because if you're going to a specialist program, my personal opinion is you should then just be doing that in your practice. There's no point spending all that money and time doing it and then mixing it up with other things. Probably doesn't make sense. So I think your approach of probably doing some courses first, seeing if you like it, and then taking a step further is kind of the most sensible approach.
Some people know really quickly,
fine.
So that's fine. You want to do it, you go for it. But I think I get a lot of people sort of, do I want to do it? How do you know you want to do it? And I think those are the ones which I think it really, like a course would benefit them. I mean, we get a lot on our MClin-Dent where they've started a diploma or an MSc, and they realise actually they really love it. So, they've then transferred onto the MClin-Dent programme. So I think it just varies. You really have to know though, because once you're in it, you're in it, and it's you don't want to
going back. So we've just got a question in from Erin. Hey Erin, how you doing? She's just asking, so she's just finished her final, so congratulations. And she's just saying that obviously their clinical times got cut short because of the whole situation. Are there any courses, so for new grads just coming out, are there any courses you personally would recommend for that?
So I mean, if you're living in London, eWisdom's a fantastic place that you can pick up on courses. I'm just trying to think. There's one called Endo Masterclass with Bavin Bova and Neha at Londec. There are so many courses. I'm starting an online endo course. I know you're doing a perio online one. So I mean, in terms of theory, I'm going to go through to cases and stuff like that. So I guess there's so many courses that you can look at if you just Google it, I guess. I think speaking to friends and colleagues and seeing what they recommend is also a really good idea.
I find it also useful, I think, when I was at that stage, to go and shadow like specialists as well. If you're not sure about something, if you want to see how it is in real life, I mean, all of us are happy to, have you for a day. So go and ask someone that's near you, just go and shadow them for a day, see what it's like as a specialist, and what kind of, even if you don't want to take it to as far as specialist training, what kind of cases are they treating? How does it work? How long are the appointments? What kind of tools do you need? So I think it's another way of learning, I guess, as well.
Definitely. You can see what the life of a periodontist or endodontist is like, and see if that's for you.
Exactly. Okay, brilliant. And then we've just got a question from, sorry, I don't know what your actual name is, but I think it's Rao. I admire you both. Thank you so much. I'm a final year student from India. What are your recommendations in terms of postgrad in the UK? How to go about? Okay, so just as we said, I think for postgraduate training in the UK, There's various routes you can take. You can do more formal training like specialist training. There's other things though, like diplomas, certificates. There are various levels of things, MSCs, all those kind of things. So they're all slightly different. So it's worth looking online. There's lots of information. But as Karina said, doing some short courses first might be helpful if you're new to the whole system, especially as well.
Yeah, there's also distance learning courses.
And distance learning, yeah.
Yeah, I mean, I know King's do like an endo distance learning one where a lot of it's online, and then they've got sort of 1 or 2 weeks per year where they come in and do sort of extracted teeth and things like that. So it might be an idea if you're from abroad.
Yeah, definitely. I think if you can find someone on the actual course right now, it's useful to speak to them and see what they think of it as well. So make the most of social media and all those kind of things to touch both of people. Okay, awesome. So that's kind of the career pathway. We've had, for obvious reasons, we're talking about perio-endo. We've had a few questions on kind of diagnosis, management, and that type of thing. So from a kind of diagnosis point of view, from my perio, with my perio hat on, according to our new classification, which is really a perio-based classification, which was updated a couple of years ago, but released in the UK about a year ago, we are now meant to call it, us as periodontists at least, are now meant to call it endo-perio rather than perio-endo. So that's one thing.
Well, it's quite fitting because endo normally comes first, doesn't it, when you manage these lesions?
Exactly.
So.
Exactly. So I agree that it does fit. But if you want to, for me, I think the actual classification of endo-perio from the one that they've done is slightly confusing. If you have a look at it, I mean, I'm not really sure it's worth us going over it because not many people are using it. Hardly anyone I know is using it.
I think it's still a good idea for you to speak about it though, because if it is confusing, it's nice to know. I mean, I phoned Reena before this and I was like, you're going to have to talk about perio classification because I don't understand that at all.
Yeah, so it's
talk to you about the endo one.
I have to say, like, in practice, you'll get away with just writing endo-perio or perio-endo. It doesn't matter, but just writing that is sometimes enough. And Karina will go on to the way you do it. But from the one that they've done in the new classification, essentially it comes under the other conditions of the periodontium, and then it's divided on that kind of third. If you can imagine the table, it's the third column. And then there's basically, they divide up into 2 categories. It's endo-perio lesions with root damage, and they've got a second category which is endo-perio lesions without root damage. I mean, from an endodontist point of view, I'm not sure if that makes any sense. Yeah, this is divided by periodontics.
Endo-perio, perio-endo is confusing enough without. I don't know because I don't know it very well, so it's difficult for me to comment. But I mean, I'm confused already.
It gets worse. So then it's subdivided even further. So in fact, you know what, I printed it out because I don't know it properly because I don't use it all the time, but I'll show you. So then it's divided up further into various grades. So you've got like grade 1, which is like a narrow deep pocket on one tooth surface. Then you've got grade 2, grade 3, and then it's like, yeah, it's really quite confusing. So I'm not sure from an endodontist point of view if that actually makes sense, like if it's worth doing that.
I mean, it's difficult. I mean, I don't know it very well, that one, but I can tell you the one that I use because I just find it very simple and easy to understand. So, I mean, it's a very old classification, but I feel like it sort of leads you into your treatment pathway. You understand where the disease is coming from, which I think is so important with perio-endo or endo-perio. So we've got sort of primary endo, which is the first thing. And that is, I mean, where you've got an endodontic infection, it's got large and it's now draining through the periodontium, so through the PDL. And we most often encounter this on lower molars because our buccal cortex is quite thick. So unlike anterior teeth or upper molars or upper premolars, because that buccal cortex is not so thick, we quite often get an abscess at the apex of a tooth. And therefore, it doesn't drain through the periodontium, it's more draining apically at the top. Whereas with lower molars, because the buccal cortex is quite thick, it's now having, the easiest path of drainage is to drain through the PDL. And we get quite often abscess in the furcation or even a narrow localized pocketing. So it's quite difficult to differentiate a primary endo lesion from a vertical root fracture because they both present fairly similarly with a narrow isolated deep pocket. So that's primary endo. And obviously the treatment for that would just be endodontic treatment, and you don't need to do any perio treatment. And then you've got primary perio. So for me, that means that there's a lot of perio disease. It's sort of surrounding the apex of the tooth potentially. So you could think it's an endo infection as well. But when you vitality test these teeth, they're responsive. So actually the whole lesion is from perio, and the endodontic part, the root canal, has got nothing to do with the development of that infection. And I'd say, again, this is something that I get referred quite frequently. Sometimes, you know, from our perio department, even to say root treat these teeth, and you think actually you don't need to root treat these at all. So that's primary endo, primary perio. And then you've got combined lesions. So combined lesions, there's so many portals of entrance, you know, of communication between the periodontium and the root canal system. The main being the apical foramen, where they communicate, but also things like lateral canals, furcal canals, dentin tubules. So loads of sorts of communication aspects. So the first combined lesion is primary endo, secondary perio. So that's where, obviously you know this, but so where the endodontic infection is communicating with the periodontium, but it's been there for quite a long period of time, and now we've got a perio involvement of that lesion as well. So that's one, which I'm sure we'll talk about the treatments later. Then we've got primary perio, secondary endo, and obviously this is where the periodontal infections got so severe, potentially it's involved a lateral canal or the apical foramen, and it's secondarily involved the root canal system. So they're both infected. And then we've got a true combined. So we've got an endo infection, which is separate from a perio infection, and then they've both increased in size and combined into one. So that's the classification I use, but I know it's old.
But I do prefer that one. I think the one we've got is okay, but it's more based on all those grades apparently will then affect the prognosis of the tooth. That's why they try to add in, does it have a root fracture, how wide is the lesion, all those kind of things. So I think it's, and it can get, because I think in general practice to have that much detail can get quite confusing. So I think the version that you use, I think is quite easy to understand, and then it will guide your treatment approach as well. So I think, I don't think there's anything wrong with using that version as such. I guess endodontists are using it, so it's probably makes sense too. So in terms of like diagnosis, obviously for a perio-endo lesion, usually there'll be two key things, which is a deep pocket and a non-vital tooth. Or, I mean, do I normally say for vitality test, I call it sensibility testing. Is that correct still?
Yeah, it's better. It's better actually,
just for people, do you know the reason behind that? Because I always get confused in terms of, I always say sensibility testing. Is it because you can't actually tell the vitality of a tooth when you test?
That's it. That's it. So when we test using cold or with EPT, we're testing the nerve supply of that tooth rather than the actual blood supply. So the blood supply is sort of, you know, that's the vitality of the tooth. So if we're testing it with a stimulus that's testing the nerve, technically we should be saying sensibility testing. So you're totally right. It's just habit.
We're just but it's good to use the right terminology as such. So okay, fine. So we've got a patient, they've come in, we've diagnosed they've got a possible perio-endo lesion. Now, often with these cases, they're really kind of, in terms of restorability, they're very broken down often, and they're not the best teeth because they've got two lesions going on. You've got a perio infection plus an endo infection. So oftentimes I find people will say, oh, it's not worth saving this, let's just extract it. And even with, I mean, you probably get this in endo, even with like very severe endo lesions, a lot of people think it's not worth doing the endo, just extract. I get it with perio all the time. And I'm sitting there thinking, I really want to save this tooth. So, I mean, my opinion on this is, and I think everyone would agree, is we should do everything we can to save teeth rather than replacing them, because everything has a lifespan, including implants. So we want to try and push it as long as possible. So with endo, like, does it make sense? Like, when would you ever say, right, I don't want to save this tooth, whether it's perio-endo or just endo? What would you look at? Like, if you got, even when you get referrals, what do you look at to assess the restorability? And is it worth doing? Like, cost effectiveness, is it worth, especially having specialist care, is it worth going through all of that? Would it not be better to have an implant? How do you sort of decide that?
Yeah, I mean, it is really difficult. I mean, the first thing is obviously, is it restorable from an endo point of view? So normally I would dismantle every restoration that's in the tooth. So I would, if there's a crown on the tooth, I take the crown out. If there's a restoration in there, I always sort of strip it bare. see how much tooth is left.
Right.
And if I feel that there is enough tooth left, I will tell the patient, you know, this tooth is technically restorable. Would you like to save it? Obviously, if it's in between, then I'll say, you know, I'll let them know and let the patient decide what they want to do. Obviously, it's unrestorable. It's a no from me. But I think for me, a big factor is patient's age, because you mentioned nothing lasts forever. So if I'm dealing with a patient in their 20s or 30s, it's a little bit different to how I'm thinking if a patient's in their 60s or 70s. Because potentially if a tooth is on, you know, very dodgy grounds, an implant may, you know, a predictable implant may last that patient's lifespan. Whereas on a 20 or 30-year-old, they're never going to get an implant lasting that sort of lifespan. So even if a tooth is sort of in the, you know, borderline restorable, I'm always quite keen to hold on to it if a patient is younger, because at least if we get sort of 5-10 years out of that tooth, it delays the placement of an implant. The second, I guess, when it comes to perio-endo stuff, is the patient's motivation. So for me, anything that's primary endo, I'm usually fairly confident, you know, we've got fairly good success rates for things like that. But the one for us that's very guarded is if it's primary perio, secondary endo. Because that we know that the perio disease is much more severe. And that's the bit that for me, I mean, I don't know much about it. You'd be much better to answer. But for me, that's the bit that I think, oh, okay, this is not dependent on the endo at all. This is dependent on the perio treatment, which is already quite advanced. I don't know how you feel.
I think I agree, definitely the prognosis is reduced, but you can, it is dependent obviously on good perio treatment, but you can get some really good results. But I think the key thing that you said there was you then need to have some perio treatment. So often what happens is the endo's done and then the perio is not done properly, so then things don't work. So I think it's really important to work with both specialties, even if you're doing all the treatment, just to be aware that I need to do endo, then I need to do perio, but really well, not just a quick scale and polish essentially. So I think it depends. If you do good treatment, you can get some great results. And even with really guarded prognosis teeth, I would always try and save them, because as you said, of course it depends on the age, but from a perio point of view, even without endo, cost effectiveness, it's actually more cost effective to hold on to guarded prognosis teeth than replace them with implants. So I think I think most people are being more conservative now, but I think it's important not to jump straight into implants. At least with perio as well. I mean, you can't really have implants until your perio is stable anyway. So if you've got something like a primary perio and there's perio elsewhere in the mouth, you kind of maybe want to do it to keep it going, and then sort out the mouth, and then kind of do a stage approach. So I mean,
I saw this patient the other day, and he'd been referred by his general dentist that he was seeing a periodontal specialist. And they were keen to, you know, hold on to these teeth. There was, I mean, the teeth were slightly mobile. There was bone loss to the apex, and it's quite unusual that I treat those sorts of teeth when it comes to endo, because I'm, you know, I worry about them. But the patient, I totally understood. We had a good chat. His periodontist had a good chat with him, that these teeth are, you know, fairly guarded. He was ongoing, very motivated to save them for as long as he could get out of them. And I think that, you know, that's such an important factor. Plus, I mean, I think implants can be very challenging in these patients, because if they've already lost a lot of bone, they're automatically closer to anatomical structures such as, you know, the sinus or the ID nerve. So implants can be quite tricky on these patients.
Definitely, I completely agree. I guess as long as it's all about consent and patient discussions and them knowing why you're doing a certain thing and knowing that it might not be forever and you're kind of tying them over. I think it's the discussion part is equally as important. So going on to treatment now. So Owen's just asking, in combined endoperio lesions on average, how long does the treatment take? So if we just take a step back and talk about what the actual treatment is. So we kind of said at the beginning, you've got to do the endo first, and then the perio. From what I understand, there's various reasons to it, but one of them is obviously you need to get the perio sorted, or the endo sorted. But I've heard that if you do the perio first and you then use like hypochlorite, can then go into the like PDL and pockets and so on. Is that right? Or what's, I heard that as one of the reasons, but I guess
not as far as I'm concerned, because usually what we do is we'll measure our hypochlorite syringe about 2 or 3 millimeters short of the working length, and as long as you're using your irrigation needle properly, so you use your index finger, constantly keeping your needle tip moving, never binding, and, you know, not pushing it beyond the apex in terms of how long your needle is measured to. We shouldn't really have an issue too much. I mean, because even in immature teeth where we've got very wide, very wide apex, you shouldn't really get a hypochlorite accident or anything like that. So for me, it's more, I think your perio treatment is never going to work unless the endo is done. So you're sort of fighting a battle because you're getting constant bacteria coming. Yeah, exactly. So I think it's a difficult battle for you to fight when the endo isn't done. And particularly for primary endo, secondary perio, if the endo is done first, we normally wait 2 to 3 months before even starting perio, because there can be some cells on the root surface which will give you regeneration, as far as I'm. Is that how you feel about it as well?
Yeah, I mean, I've had, sometimes I only wait like a month or so, but I think some time duration for a bit of healing, I think, is important. So
not obviously for primary, perio, secondary endo. But obviously for the other that we talked about.
Yeah, exactly. And so in terms of how long the treatment takes, I guess, Owen, are you referring to the actual treatment itself? I guess, how long does your average endo take, would you say? Does it vary? Like, I'm guessing it varies, or?
Not really. I mean, most of my treatment, about sort of 90% of what I do, I do in one visit, in single visits. So there's no significant difference between single visit endo and multiple visit endo. So a lot of what I do is single visit. So for a molar, it's typically, I mean, I would book a 2-hour root canal treatment. And that includes sort of placement of the core. So for me, I'm done at that stage, and then it would be back to my periodontist to, you know, carry on with treatment as they needed to. And if the tooth needs a cuspal coverage restoration, then obviously their general dentist can do that, or the perio, or depending on how competent they are at both of those things.
How do you decide if an endodontist needs to treat the patient? What's the kind of key markers?
In terms of, should a general dentist do it?
Or so if you're a general dentist. If your general dentist case came along, it was perio-endo, would you say, like, would all perio-endos need to be referred, or would you say what are the key things that you would look out for?
No, I think, like, it depends how confident the patient's dentist is at root canal treatment. I mean, if they're happy to do root canal treatment to a good standard, then I think it would be fine for their general dentist to do it. I think maybe success rates do vary when it comes to general dentists and specialists. So I guess success rate, depending on what the patient says, costs and things like that. But I think very much it's down to that the general dentist to see whether they want to do it or refer it, really.
Is there anything on, like, because last time I read, because I know they already have introduced the complexity 2 level as well. Is there anything on, like, curvature of the canal or anything like that to look out for, which makes it more difficult?
Yeah, I mean, obviously calcified canals, which can happen with perio-endo lesions, because if there is a severe amount of perio, there is some evidence that you can get calcification of the canal. So calcified canals, things that are curved. I think once you've done a little bit of endo as a general dentist, you sort of look at a radiograph or you look at a cone beam CT, and you actually know, this curvature is going to be difficult for me to do. So I think it's very much on how competent you think you are at negotiating it. I really don't like to sort of say, no, that's not for a general dentist to do, or only a specialist can do that. I feel like it's so, people have such different skill sets. Some people are good at certain fields of dentistry and some people prefer other fields. So I think it's very much on how confident you feel that you can treat that tooth well.
Fine. No, I guess I agree with that from a perio point of view as well. It just depends on how confident you are, what training you've had. As soon as you feel uncomfortable, both because of complexity or the extent of the disease, I think it's worth, even if you get an opinion, I think it's quite nice if you're not sure about referring. Just had a question from Estuardo. He's just asking the size of a perio-endo lesion. Is that dependent on the amount of bacteria or the time it's been there, or both?
I mean, time definitely has a factor. But then some lesions can grow very quickly and some lesions grow more slowly, even over a long period of time. So I think that's sort of a difficult question to answer. It's as big as as long as a string. It's difficult to, I don't know.
Yeah, I would agree.
It just depends on how aggressive the bacteria is. I don't know from a perio point of view if you.
And I think also bone density and things like that would have a role in how much bone destruction, things like that you get as well. So I think it would vary between individuals. I don't think you can say if there's lots of bacteria, you will get more of a radiolucency or anything like that. I think it's probably a mixture of things.
Even the virulence of the bacteria, I guess,
true.
influence these things.
Exactly. Okay, so we've talked a little bit about treatment of periendo. Just whilst we've got you here, I just wanted to spend a bit more time on just endo. And I always get asked when I do perio kind of online education, what are the common mistakes people make? And I can probably list out a couple. But from your point of view as an endodontist, are there any common mistakes you find people make in endo?
So I would say the most common ones are ledges.
Okay.
So to ledge, when it's very easy to ledge a canal.
Right.
Before I did my specialist training, I felt like I never ledged anything. Like if I can't get down it, I just can't get down it. But it's very easy to ledge a canal, and that usually is why you can't negotiate the canal to length. So if you're getting very stuck, so I would say the tips to improve that would be to get good coronal access, so coronally flare, before you try and take hand files all the way to length, because it lessens the curvature that file is going to have to go down, and also pre-curve your hand files.
Right.
So don't put a hand file in straight. You always want to put a kink on it, not a sharp kink, but just a little bend before you put that down, and that will help avoid creating ledges. Also things like perforations, fairly sort of common and horrendous when they happen, which makes you feel terrible, but is a common complication in endodontic treatment. And I'd say the other one, probably things like missed canals. So MB2 in upper molars, quite a common problem. They're difficult to find, difficult to negotiate, and about 95% of upper sixes, 70% of upper sevens have them. So that's quite a significant amount.
Huge, yeah,
it's quite a significant amount. So they're commonly missed. Even lower molars, about 25% of lower first molars have 2 distal canals. So I'd say missed canals is also a common complication that people.
What about like fractured files? Like, is there any tips you can do to minimize that happening?
I think some of it is what files you're using. So make sure that you're using a decent brand.
Do you have a recommended brand?
Well, a lot of the files that I use are Dentsply Sirona. So I tend to use those the most. They are expensive files, and you can get ones sort of in the middle. But I would say the very cheap branded files, they're a little bit more prone to breaking. So you pay for what you get, what you get. The other thing is there's different types of file fracture. So there's cyclic fatigue and there's torsional fatigue. Cyclic fatigue is usually when you break a big chunk of instrument. So for example, if you've got a rotary file and you've kept it in the canal for too long, then you'll get the metal will, you'll be putting the metal under too much pressure and you'll get a big chunk of file breaking. Torsional fatigue is where you've then put a little bit too much pressure on the file. So the tip has basically locked into the base of the canal and the rest of the file has continued to move, and then that comes off. So tips to stop that are making sure that you're using your file correctly. So putting it in the canal for a couple of sweeps, taking it out, cleaning it, and then using it again. And with torsional fatigue, not putting too much pressure on your file. So if it's not going, stop, use your hand files again to get it clean. But cyclic fatigue and torsional fatigue can happen with hand files in the same method as well. It's just a little bit more common these days to have it happen with your rotary files.
Fine. If it does happen, I guess, especially as a young dentist, people always panic. And what would be?
I still panic.
I'm sure we all. But what do you do? Like, do you stop, and what would be like the immediate action for that?
So I think stop. You want to tell your patient what's happened. I would probably not tell them while they've got all the rubber dam and everything on, because it's just, people say stop straight away and tell the patient, but actually you're panicking, everyone's panicking. I think the best thing to do is probably dress the tooth, sit the patient up, explain to them without rubber dam on, so they're not like panicked under the rubber dam. And I think it's the way you discuss it. So I always explain to patients, even with simple cases, that there is a risk that file fracture can happen. So before they even start endodontic treatment, they're fully aware of the risk. And you'll get some patients that have this understanding of course we're using fine instruments in the canal, those sorts of things happen. And then you'll get the other spectrum that sort of their eyes widen and say, what do you mean you can break stuff? Like, tell me about it. And you fully explained all of those things before you've gone into treatment. And that will make you feel better if it happens, because you know that you've told that patient that that was a risk. So that's one thing. If it does happen, what I would normally say is it's very much influenced when it happens. So say it's your first file that you've gone in and it's fractured and you haven't really cleaned that root canal at all. That's more of a significant problem, because then you haven't done a lot of the work that you needed to. There's a higher chance of failure, especially if that tooth has a lesion. If it was a vital tooth, it's not much, as much of an issue, because there may not be as much bacteria down there. But if it's necrotic with a lesion and it's happened early, I would then say that the next step would be to sort of, once you've explained to the patient, say that there are various pathways, and I would consider a referral to a specialist at this stage if you're not comfortable with removing instruments. If it's happened very late in your procedure, so say for example you've pretty much cleaned it, it's your last file that's happened on, it's very unlikely to affect the prognosis, because you've already done the majority of your cleaning and shaping. So again, I would relay that to the patient and say, look, you've got a couple of options. One, I can just fill up the rest of the canal and we can see how things go. And obviously if it causes a problem, we can then refer you. Or if you prefer, I can refer you and get that opinion now.
No, it makes sense. I guess communication is key. I think breaking bad news is always hard. I've got it in perio as well, which is going to lose the tooth. But I think, as you said, it's the way you explain it and the fact that you pre-warn them and you said, oh, remember I said this might happen. It has happened. So X, Y,
do you have consent forms in perio?
I do, yeah. I do written consent forms. I guess you do as well. I think depending on kind of what treatment you're doing and the complexity of it, it might be worth just having a written consent form. It takes a few to fill out. It can make things a lot better going forwards, I think. So
I think legally it doesn't make much of a difference, but I think from the patient's perspective, they've had time to read it. They feel like they've signed something, which is also an important thing. I think you're both on the same page when you start, aren't you? So
yeah, exactly. Just had quite a few questions come in. So have you tried Night-Eye Edge endo files? They claim to be more durable than Dentsply. What's your opinion on that?
I mean, I have heard of Edge Endo. I think it's a big thing in America at the moment, and it's come over to the UK now. I personally haven't tried them, so I can't tell you. They're definitely a lot cheaper than the Dentsply files, so that's one thing. But I don't know about their durability. I don't think there are many studies on that sort of thing at the moment. So I haven't personally tried them.
Right, and I guess it's what works in your hands as well. There's a bit of that for all these things. Rachel's just asking, in terms of referral pathway for endoperio, does it need to go through a dentist or can a hygienist make a referral? Because from my point of view, I get lots of referrals from hygienists, but I guess would it be the same for endo? Is there any restrictions? I don't know if there is, or
not really. I mean, patients self-refer themselves, so for us there's not really too much of that. But if it was an endoperio lesion, I think it's quite important that a periodontist or a general dentist is involved, because it's going to have a massive impact on long-term prognosis of that. So definitely that, it's great for a hygienist to be doing the OHI and doing all their treatment that they need to, but it's quite nice to in terms of, I think you have to be working with a dentist or a periodontist. So I would want that side of things, but referral wise it doesn't make a difference.
Yeah, absolutely. Ali is just asking, I think you may have already covered this, but what's the prognosis for a broken file in the apex once the canal's been fully cleaned and shaped? I guess we kind of used to said that's
pretty good. Pretty good. If you're happy, it's your last file. Like I said, trying to get a file out when it's at the apex is very, very difficult and often quite destructive for the tooth. So you're looking at really bypassing a file like that if you can't get brain line access to it. So I personally, for those ones, if it's happened at the end of treatment, I'm thinking just fill it up, see how it goes. We can always go back into it if we need to, if it doesn't settle down.
Fine. And in terms of the actual system, in terms of rotary system that you choose, how did you decide the one you chose? And are there major differences between all the brands, or is it just, good, as you said, good quality is important, but then between that, are there any things to look out for? What is a good system, would you say?
So in my surgery, I've probably got about 5-6 systems of rotary files, just because I find certain things good for certain cases, and certain things that are good for other cases. The file system that I use the most is ProTaper Next. I really like it. It's a really simple system, and I quite like the taper on it. I find it quite conservative, which is important for endo, because a large reason that teeth fracture are due to vertical root fractures. So I used to use Pro Taper Gold a lot, and it's still a fantastic system, but it's got quite a heavy taper on it. So I prefer Next for that reason. And I also find it negotiates curved canals really well. The only thing you have to be a little bit careful of is the X1, which is the first file that you use in it. The tip is a little bit delicate, so you need a good glide path before you use that. When it comes to other rotary systems, I think it very much depends what works in your hands. So there are reciprocating.
Said that in the comments. John's literally just said the best system is what works in your hands.
Yeah, exactly. Yeah. I mean, there's reciprocating systems, which a lot of general dentists are using now, like Wave 1 Gold or Reciproc, just because they're one file systems. So easy to remember, like this is the file I use, I pick it up, and that's what I do. But I think that the negative with sometimes reciprocating systems is you lose some of the tactile feedback that a rotary system gives you. So they're all good. I think you just have to, whatever you're whatever you've trained on, practiced on, go for that system. And then obviously you'll learn naturally the limitations of it. I think practicing on plastic blocks first, then extracted teeth is really, really good. Just because you get plastic blocks always feel different to natural teeth, but it's good just to start with. And then extracted teeth, I think gives you a good idea of how that system is. So lots of practice, I would say.
Absolutely. So moving on a little bit to kind of technology and things, with perio, not that much has changed. So we're still on periapicals and things like that. Whereas I think for endo, a lot of CBCT is now used. What do you use that regularly, or when do you decide if that's needed?
So CBCT's come into endo majorly. I saw Shannon had logged in earlier and had put a comment down. So he's one of the main people that have created some guidelines. So we've got ESE guidelines, which is our European Society of Endodontology guidelines. And what they've said is sort of it's given a little bit of guidance about when we should be using CBCT and endo. So the main things it talks about is abnormal anatomy before root canal treatment or root canal retreatment. So things like invaginations or anything that's sort of slightly more complex, you're not sure what's going on with the anatomy, a CBCT is a really good idea. If you're unsure about the diagnosis, because quite often what we find is a tooth might not look like it's got a periapical lesion on a radiograph because it's a 2D X-ray, lots of limitations towards it. But actually, you take a CBCT and you see a very large lesion. So if you're unsure about the diagnosis from an endodontic point of view, CBCT is a good idea. Surgical endodontics, we use it quite readily to check the anatomy. Things like trauma, resorption, any endo complications like perforations. You just get this three-dimensional view of what you're looking at. So you've got a really good idea of what you're going to say to the patient before you start treatment. So you're not doing anything invasive, and you've got a really good idea of what you're approaching. So I would say, I mean, there are clinicians that use it for every case. And then for me, I don't use it for every case. It will have to have something that I'm a little bit unclear on the periapical radiograph for me to then think, okay, I want a CBCT. For things like resorption, surgeries, anything that I'm not sure about diagnosis wise, anything with complex anatomy, it will definitely be a cone beam CT first. I'm surprised it hasn't come out too much in perio, because it shows bone levels really well.
It's used a lot in research, and they're starting to use it more in the kind of regen research and seeing how much bone has regenerated and all that kind of stuff. But in general practice, I guess because of the vast amount that you'd have to then, because I guess with endo it's usually just one tooth, whereas with perio it's usually a generalized condition. So I guess maybe because of that, and then the time it takes to interpret the whole mouth. But I guess for us,
so maybe, I mean, if you're treating a specific I mean, is it any good for like regeneration to know? Because I'm not that much about perio, but how many wall defect it is and things like that.
Yeah, but I guess for us, when we raise the flap, we can see it anyway. And whether it's a 2 wall or 3 walls, you still have your materials ready. So I think maybe in terms of preparing yourself for treatment, but for us, I guess the end result is a shallow pocket. And as long as we get that, we don't really mind. So I guess kind of success determinant factors are slightly different, I guess. Maybe that's why. But I think things may change.
Yeah, maybe when more research comes out, like success rates for 2-walled or 3-walled or things like that, maybe.
Maybe. No, that's really, really interesting. So you obviously really, we've only got 10 minutes or so, so I had a couple of little questions for you away from treatment and so on. So you're obviously really passionate about what you do and you know, enjoy what you do, but is there any parts of your job as an endodontist that you don't perhaps enjoy as much, or are there anything like negative about the job?
So I like endo because it's really varied. I would say that the disadvantages and the things that I don't like is it can be quite stressful. Okay. So you're basically producing these white lines that are going to show up on an X-ray at the end of treatment, and if something's not quite right, it's really obvious. So it can be a really stressful job, I would say.
You still get nervous when you're waiting for your radiographs to come through?
Yeah, yeah, I do. Do you know what I do? People ask me that, and yeah, it's still like when I'm waiting for my master cone and my final one, you get a little bit like, okay, so, how's it going to be? Get it up quickly. But I think it's just because, you know, it's such a precise speciality. You're working within millimeters, and that can, you know, 1 millimeter can determine if you've got a good result or not a good result, and I think that can be quite stressful. So it's very enjoyable as well. So, you know, I don't want to take anything away from that, but I would say, you know, it can stay with you. If something bad has happened, if you fracture a file or something like that, it can stay with you. For me, you know, it stays with me for like a week. It will disturb my sleep. Yeah, it will still disturb my sleep for a couple of days. Like I will wake up and I'll be like, oh God, I wish I hadn't done that. Wow. So I'd say, you know, it does have that. And I think a lot of endodontists are the same. Yeah. If I speak to a lot of my colleagues, yeah, it does stay with you a little bit, those sorts of things. So it can come home with you to those sorts of things. I think just because it is so obvious on a radiograph and it's such a precise speciality. But apart from that, I think, you know, it's full of positives. It's a really varied speciality. It includes surgical stuff. You know, you've got so many endo gadgets, which is always fun. You know, there's always something new coming out. The research is great. So there's so many positives with it, but that is one big negative, definitely.
What's your favorite latest gadget that you're using?
I'm trying to think. The latest, I mean, we've just bought a cone beam CT about 6 months ago. So that's definitely that's on the top of my list at the moment. But I think in terms of if you want to invest in endo, ultrasonics are a great. You know, they've got a lot of applications. So, you know, it can help you with perio, like you guys, because you guys use the magnetostrictive, don't you? More the cavitron.
There's 2 types of cavitron with magnetostrictive, or you can use piezo as well. So piezo is actually becoming a little bit more popular now with the EMS system. So a mixture of both. In terms of effectiveness, they're both as equally as effective. But you can't go wrong with a really good ultrasonic scaler, I think. Yeah, because for endo, I mean, we can't really use the cavitron because the motion of the tip is more elliptical, so you lose that control. Whereas for piezo, you've got a linear motion, so you can cut more precisely. But it's fantastic. I mean, right from searching from like calcified canals, like MB2s, things like that. You can clean your pulp chamber up with them at the end of treatment. You can agitate your irrigant. So the use of, you know, remove instruments. So there's a massive list of what you can do if you have a piezoelectric scaler in endodontics. What's your opinion on the laser? Because I think for me, for perio, there's for periodontitis, what we know, there's no adjunctive benefit of using it for treatment of periodontitis. It's great for surgery, but not for periodontitis. What's the kind of deal with endo on that?
Yes, I actually went on an online webinar. One of the guys who is launching it, he asked me to sort of have a look at the laser stuff in endo. Lasers were a fairly big thing a little while ago in endo, where, you know, it would help with disinfection of the root canal space. There were some negatives with it, and it sort of lost favour. And now I think it's coming back in, you know, for disinfection again. So yeah, I mean, I don't use one. I think hypochlorite, for me at the moment, that's where the evidence really is. But I think if there is more research that happens in lasers, maybe I'll change my mind. But at this stage, I'm not using that. Yeah, and I guess you always have to ask yourself, what's the additional, if you're getting good results, what's the additional benefit? If there's no change in patient experience, you know, why do we use it? I guess the problem with lasers, because with perio as well, they don't go around corners, so that's half the problem. And I guess does the same thing with canals,
pockets, same things. I think when you understand the science, it's interesting, you know, in terms of application.
With endo, I think what they're doing is they're putting like an irrigant in, which has like a photo, something that when the laser puts the light in, and then it activates that that in the irrigant, which helps to sort of disinfect better. But yeah, I haven't personally tried it. Someone tried to sell me a machine a little while ago, and I was like, it's just
especially when you're used to something that works, I think it's hard to, but I agree, we should always embrace technology and new developments.
Definitely. Are you using it for surgery then?
I don't actually. I prefer, like you with the hypercord, I prefer a scalpel and just keeping it traditional. That's what I've trained on, and I find I have more control with it. So yeah, I haven't yet changed. I'm not sure I will. So just a couple more questions if you don't mind before we finish. A lot of people are asking, and I get asked this as well, in terms of obviously people interested in applying for specialist training, things like that. We've got to tick off things like audits, and you know, even just generally, it's good to do audits in practice. Are there any kind of, because perio audits are not the most interesting with like the BP.
Neither endo audits.
What can you do endo audits? Are there any kind of good ones to do in practice?
Do you know, I used to hate audits when I was applying specialist training. I always tell people when they call me, oh yeah, make sure you're doing some audits. I think you could go for your record keeping on your endo, which is hugely boring, but you know, making sure that your endo records are adequate. You know, you've written rubber dam, you've written what hypochlorite, the concentration, all that sort of thing. So there are definitely things like record keeping audits. You could go for like the technical quality of your root canal filling. So you could look back and say, you know, length is adequate. So within 2 millimeters of the radiographic apex, you haven't got voids. So those sorts of technical quality audits. I think that's it really. I mean, I'm sure there are more, but I'm not the right person to. You know, whenever there's an audit lecture on, it's like I'm out.
It's not the most interesting thing. I guess with audit, you want to do something where it does have an impact on your care, and you want to re-audit and those kind of things. So
when I was at Guy's, actually, we did one on recall rates. So after the root canal treatment was done, was that patient recalled? Because for root canal treatment, you're meant to recall your patient yearly, up to 4 years until the lesion is healed. So that was one that I did there. So maybe if they could do that.
Do you do that in practice then? Do you have patients who you see on a yearly basis?
We try to, I will say. So if there is a lesion, I will want to make sure that lesion has healed. But again, my recall rate is shocking, because usually patients go away. I mean, I always tell them, look, I'll set you a reminder on the system to come back in a year. I don't even charge for my recalls, because I just want to see that things are better and that patient is okay. But I think the amount that come, I've probably got a 20% recall rate, I would say. I could push for it, you know, we could call them, but we do send them an email reminder at a year. But I think just with they're out of pain, and usually the general dentists I work with quite closely, I'm hoping that they've recalled my patient, which I'm sure they have. So
if you had, so just a side question, if you saw a radiograph, endo was done say over 4 years ago, and there was still a lesion, do you have to do anything, or just keep an eye on it in terms of size, or does it mean there's a problem?
So according to the ESC guidance, if it's not healed within 4 years, you should classify that as a failure, and it needs redoing, or you know, further management. However, I think like the best thing to do is have a look at the preoperative radiograph. So if someone comes in and they've had they've still got a lesion and they've had a fantastic endo done, what I normally do is ask them to get hold of the previous radiographs, because quite often, you know, there's been studies in endo which are showing this, you know, lesions are still healing 17 to 27 years down the road. So as long as you're not seeing a huge lesion, of course, that you're going to manage. But if it's fairly small, I would probably ask to see the previous radiographs, just to see, because if things are getting smaller, I would definitely not jump into redoing something like that. I think then you just want to keep an eye on it. Whereas if that lesion is getting larger, or staying the same size, you may then wish to intervene. Right,
fine, great. Well, we've gone through quite a lot. I think we've gone through things from career pathways, taking the next steps in terms of developing your career, to the actual endo perio side, plus lots of tips on endo for those of you who we all want to improve. But in terms of developing ourselves, there's so much we can do.
I'd be curious to know from you actually, like,
yeah.
do you treat a lot of primary, perio, secondary endo, and what sort of success have you had with them?
Yeah, I would say in terms of how many, I would say probably not that many. I'd say about 3 or 4 a month, not huge amounts, but a fair amount. I think the key thing is kind of educating my referrers on what is a perio-endo lesion, because sometimes it can be confusing when you're looking at a radiograph, what exactly is this, and knowing. But from the ones I've done, I mean, even the ones I'm thinking in my head where you've got nearly like 90% bone loss and it needs an endo and root surface debridement, when I've done a radiograph a year or so later, it's really surprising as to the results you can get. So I'm quite, I used to be very pessimistic with endo, perio, endo, but I think now I would always say give it a good go. That's my kind of approach on it usually. Yeah.
Oh, that's good to know.
Roshni, yes, this will be saved on the Instagram TV. Great, Reena, thank you so much. I know you're super busy, especially with everyone going back to practice. I've had quite a lot of people tune in, considering it's a Friday night and everyone's found out the news, so everyone's kind of a lot of havoc right now. So thank you for all of you guys who tuned in live. Thank you so much, Reena.
You're welcome. Thank you for having me.
No, hopefully I'll see you in real life soon.
Yeah.
But good luck with the reopening of the clinic. And,
yeah, you too.
Yeah, hopefully we'll speak again soon. Thank you so much.
All right. Bye-bye.
Take care. Have a good evening. Bye. Hey guys, hope you really enjoyed that. Reena's amazing. Check out her page. She's got so many educational things out there. So yeah, I'm doing a couple more lives tomorrow. It's obviously going to get a little bit busy now that we're going back into practice, but I want to keep up the lives. If you are up for it, I'm happy. Maybe let me know, give me some feedback. I'm happy to do things maybe once a week or something. Like the Q&A thing has worked quite well. So, or if there's any other topics, any other people that you'd like me to get on here and interview, please let me know. But I'm really impressed you're here on a Friday night. So yeah, thank you for tuning in. Enjoy your weekend, and yeah, stay positive. And for those in the UK that are reopening from the 8th onwards, good luck with all the preparation. I'm so happy we're going back. So yeah, even though it's going to be a slow start, it's better than being at home. So finally we can look after our patients. So take care, good night everyone, and enjoy your evening.